Levels of Evidence. A deep dive into evidence-based practice. Welcome to another episode dedicated to demystifying evidence-based practice. What are the levels of evidence? Let us start with a basic question. What exactly are the levels of evidence? Imagine a hierarchy that ranks the reliability of scientific research, helping us distinguish studies that are most likely to provide unbiased answers to pressing clinical questions. The core principle here is simple yet powerful. Not all evidence is created equal. The evidence pyramid explained. This hierarchy is often visualized as a pyramid. At the summit lie the studies that do the best job of minimizing bias and random error. As we move down the pyramid, the potential for bias and uncertainty increases. Today, we will walk through each level, so you come away with a clear understanding of how to interpret research findings. Systematic reviews and meta-analyses. First, we have systematic reviews and meta-analyses. A systematic review is a thorough and impartial synthesis of all available research on a specific clinical question. Meta-analysis is a statistical process that combines the results of these studies to produce a more precise estimate of an effect. Because these approaches compile multiple studies, they increase statistical power and reliability. They are considered the foundation of robust scientific evidence. Randomized controlled trials. The next level is randomized controlled trials. In these studies, participants are randomly assigned to either an intervention group, which receives the treatment, or a control group, which receives either a placebo, standard care, or a different treatment. The process of random assignment is crucial because it ensures the groups are similar at the outset. Randomized controlled trials are viewed as the gold standard for demonstrating causation, that is, showing that an intervention truly causes a particular outcome. Blinding, or masking, of both patients and researchers adds another layer of protection against bias. Quasi-experimental studies. Moving further down, we encounter quasi-experimental studies. These studies also test interventions, but they do not employ random assignment. Examples include non-randomized controlled trials, in which assignment is based on clinic, date, or patient choice, and before and after studies, which measure outcomes in a single group before and after an intervention. Without randomization, there is a risk that the groups differ in important ways from the start, making it harder to be sure that the intervention is responsible for the observed effects. Observational analytical studies. The next category consists of observational analytical studies, such as cohort studies and case control studies. In a cohort study, researchers follow a group of individuals over time to see who develops a disease or outcome of interest. These studies can be prospective, looking forward in time, or retrospective, looking back at records. They are well suited for assessing risk and incidence. Case control studies, on the other hand, start with subjects who already have the outcome and look back to identify prior exposures or risk factors. Both study types can identify associations, but they cannot definitively prove causation due to the possibility of confounding variables. Descriptive studies. Descending further, we reach descriptive studies, including case series and case reports. A case report details the symptoms, diagnosis, and treatment of a single patient, while a case series collects such reports for several patients. These studies lack a control group, and while they are useful for identifying new diseases or rare side effects, they cannot test hypotheses or prove relationships. Expert opinion and background information. At the base of the pyramid lies expert opinion, editorials, and background information. This level encompasses the views of authorities derived from their clinical experience, physiological research, or textbook summaries. While valuable for generating ideas and providing context, this evidence is the least reliable for guiding clinical decisions because it is not based on systematic research. Nuances and alternative hierarchies. Let us pause for an important nuance. The hierarchy I have described applies most straightforwardly to questions of therapy, treatment, or prevention. When asking about diagnosis, prognosis, or quality of life, the pyramid shifts. For instance, a high-quality cross-sectional study may rise in importance for diagnostic questions, and cohort studies may become strong evidence for prognosis. The GRADE approach. Many organizations now use the grading of recommendations, assessment, development, and evaluations approach, which dynamically assesses the quality of evidence. A randomized controlled trial may begin as high-quality evidence, but factors such as bias, inconsistency, or imprecision may lower its rating. Conversely, a very pronounced effect can increase the quality rating, even if the study design is observational. This system also distinguishes the quality of the evidence from the strength of the recommendation. Quality of execution matters. It is essential to remember that not all randomized controlled trials are created equal. The rigor with which a study is conducted, its size, blinding, and rate of participant completion greatly influences its strength. The quality of execution within each level is as important as the level itself. Preclinical studies. Finally, let us consider animal and laboratory research, often referred to as preclinical studies. This foundational research underpins our clinical knowledge but is typically not included in the standard pyramid when making decisions about patient care, since results in animals do not always translate directly to humans. Translating evidence into recommendations in practice. Clinicians translate levels of evidence into grades of recommendation. These recommendations consider the quality of the evidence, the balance of benefits and risks, patient values, and cost. A strong recommendation is based on high-level evidence and means the intervention should be offered to nearly all patients. A moderate recommendation indicates most patients should receive the intervention. A weak recommendation suggests it may be considered but is not necessary, and a recommendation against an intervention follows evidence demonstrating lack of benefit or the potential for harm. Conclusion. To conclude, understanding the levels of evidence is essential for critically appraising scientific literature and making decisions that are genuinely grounded in research. This hierarchy provides a roadmap to distinguish the most reliable sources of knowledge, empowering clinicians, researchers, and policymakers to make informed choices. Always remember, the strongest available evidence should guide clinical practice. That's it. See you on the next episode of the Everything Surgery podcast. If you enjoy our content, please like, share and subscribe.